Welcome to the first concurrent session of the day. This one is called, I'm on the wrong page, In the Mix. I'm a DJ, I appreciate that. Developing integrated and innovative programs for gay, bisexual, and queer health. So we have a collection of presenters here who are all beautiful and fascinating. There'll be 4 presentations. We'll give them each 15 minutes to share what they have to share with you. And then at the end, we'll have a few minutes for questions. So I'll appreciate if you have questions to keep them in mind and then hold them until the end, okay? We're gonna start by introducing or inviting Stéphanie Black to come up and join us, and she'll say a little bit about who she is, and she'll take it from there. Thanks.
How do we do it so the speaker notes aren't up there?
I'll get you.
All my secrets. Perfection. Thank you. Good morning, everyone. Bonjour tout le monde. I'd like to start by acknowledging the ancestral, traditional, and unceded territories of the Coast Salish peoples, and in particular the Squamish, Musqueam, and Tsleil-Waututh First Nations, on whose territory we're meeting today. I'm Stéphanie Black, and I'm a PhD student in education at UBC. And for the past 10 months, I've been working with Travis Salway on a study on integrating mental health services into sexual health clinics. So our study is about low-barrier sexual health clinics, and these clinics have 3 characteristics that make them unique. 1, they have no primary care referral required. 2, they're low barrier, which means that they're free of cost and identification is not necessary. And 3, they have competency and safety for LGBTQ clients. So these results here, this graph, is from a previous study that informed ours, in which clients of sexual health clinics filled out a waiting room survey on mental health. And you can see here that 72% of respondents with mental health or substance use needs haven't talked to a provider. And 39% reported at least one mental health need, the most common of which were depression, anxiety, substance use, as well as partner violence, self-harm, and suicide. So in our follow-up study, we wanted to understand what STI clinics can do to address these unmet needs. We sampled in 6 low-barrier sexual health clinics, 4 of which were public health and 2 of which were nonprofit. We had 22 participants, 14 nurses, 3 physicians, 3 administrators, and 2 educators or counselors, and we did all these interviews in the Greater Vancouver area or in Victoria. And we also wanted to note that a large proportion of the clients at all of these sexual health clinics are gay, bisexual, or queer men. For example, we talked to folks at the HIM clinic, and you'll be hearing more about the HIM clinic from our next presenter. So our interviews had 3 parts. The first part, we wanted to know about the people that we were talking to, and we wanted to understand their role and experience in the STI clinic. The second part was how they address their clients' mental health needs. And the third part was trying to get their ideas for future models for integrating mental health care and sexual health care. So now we're going to move into the results section, and I'm going to share with you a little snapshot of what we learned. So we noticed that our clinicians, while they had varied professional backgrounds, they all were very similar in 3 ways. Whoop. Stand by. They were motivated to address upstream health and determinants of health. They all saw sexual health and mental health as interconnected, and they all noted that anxiety was a prevalent concern in their day-to-day work. So here's a quote illustrating the complexity of the connection between sexual and mental health. This person said, "So they're in crisis because they've been named as a contact of syphilis, or they have a rash in the genital area, and they're sure it's a sexual infection, but they're also about to get evicted from their home, and they've been struggling with chronic depression, but they're not enrolled in MSP, so they can't get medication or care." This next one here is a participant giving an example of how some of the clients keep returning, even though their risk level is very low, but they're anxious about their sexual health. They said, I saw a young man, probably in his early 20s, and his risk was very low, and he knew that, and he hadn't had any major risk event, but he was coming in because he was really worried about his HIV results. And I think when he had initially tested, he still wasn't out of the window period, so he was returning, and I think for someone like that, there's just a generalized anxiety going on. Now, the second part of our results showed that there were several barriers and constraints making it difficult for these clinicians to address mental health needs during appointments. The first three were that the clinic mandate or funding model made it a challenge. The second part was a siloing of services. And the third was lacking of a familiarity with mental health referral resources or challenges in navigating the system. So this is an example of what we mean by silos. This person said, I think we carry the baggage of history, and the history is mental health people got locked up and segregated and ostracized. And I think we're dealing with that, and I still see it in acute care. It's like you've got mental health wards and mental health teams, and mental health and substance use is over here, and other mental health care is over there. I've been really trying to get them together, but when we keep segregating it all out, it's hard to do. Now, this clinician described a situation where they felt that they needed to coach their client in order for them to get the care that they needed, because otherwise it would take them too long to access care. They said the kind of mental health stuff that we would see really directed to sexual health would be someone who wasn't coping with a herpes diagnosis or STI diagnosis, for example. So we would refer to mental health, and I would coach them on how to make that call, because you're cold calling a stranger. I would tell them, so when you talk to this person, don't fake it, but don't hold it together, as odd as that seems, because if you sound like you're okay, you're not going to get in soon enough, and I'm reading that you're not okay. On a more positive note, we had some facilitators or enablers that came up. One was the flexibility in the time that they were able to spend with clients, and this was particularly noticeable in public health clinics. The second was the low barrier or safe nature of clinics, because that helps people divulge information that they might not be comfortable divulging when they had to show ID. And the experience that clinicians gain in counseling clients over time really helps them to identify these needs and become more skilled in addressing them quickly during an appointment. So here's a quote on appointment flexibility. This person said, so thankfully we're in a really supportive environment. This clinic is unlike any other clinical environment in that we're not time limited with clients. We take as long as we need, which I would be hard pressed to name another environment where we do that. The low barrier nature of the clinics allowed for more confidential interactions with clients, and one clinician told us, the actual fact is, for lots of people, it's not safe for people to know what they're doing sexually, who they're having sex with, and who they fall in love with. So people can maintain their anonymity with me. I always say, you never have to tell me your real name. I can connect you with people, and then if you need to use your MSP with those people, you will need to use your real name with them. But for me, we can just stay this way. You don't have to tell me. We protect people's privacy that way. And finally, we had our last part of our interview where we had people share visions of what they thought would be some solutions to integrating mental and sexual health care in STI clinics. And we really asked them to dream big in this area and just think outside the box as much as possible. So while we did get a lot of we got varied answers, but they were all really connected in the way that people really focused on the co-location of mental health providers within STI clinics or within the same building. And many people noted that this person that would be the mental health provider would have to have some really good expertise and sexual health knowledge. One of our participants explained what kind of person that should be co-located in the STI clinics. They said, I don't even think it needs to be psychiatry. In fact, many people find that quite off-putting, so a counselor would go a long way. Even a registered clinical counselor or psychologist who has training in cognitive behavioral therapy, but also has knowledge of stigma around maybe sexual practices or sexual fetishes, or a good understanding of addiction, and a good understanding of mental health concerns with regards to anxiety and depression for sure. So in summary, we found that sexual health providers are a distinct self-selected group of people who are often motivated to look beyond STI and reproductive health needs. Mental health concerns frequently arise in sexual health visits, particularly with anxiety. And this work can be supported in several ways by reducing silos, like improving referral pathways from STI clinics to mental health providers, co-locating sexual health and mental health services, and identifying high anxiety, low STI risk clients who frequently access sexual health services and assessing their broader mental health needs. Now I know some of you may be wondering, what are the next steps? Travis is working on a service called MindMap, and it's a mental health service finder tool with the option of selecting services that are queer and or gender affirming. It uses maps and a database of low barrier services to help clinicians identify the best referral pathways for their clients. Travis is also working on an anxiety study coming soon, pending, I guess. And we're putting forward recommendations to administrators on co-location of mental health service providers. We'd like to thank our study participants as well as our study team and our funder, the BC CDC Foundation for Public Health. Thank you, merci. And I think we're doing questions later.